Hi everyone, thanks for joining. My name's Anya, I'm one of the 6th years. So this evening we're just going to do some Module B SBAs. I think there's about 32 questions, so I'll try not to spend too long on each question just so the session doesn't last too long. But please feel free to ask any questions, and it would be good to have it as interactive as possible. So please do put your answers in the chat or unmute yourself, whatever you prefer. But yeah, let's go. I won't read the question out, but I'll just leave it up for a few minutes and then show the answer. And yeah, like I said, put anything in the chat if you've got any ideas. Anyone have any thoughts? This one. Okay, we've got someone saying E. Move on. Yeah, so E is correct. Well done, Molly. This is a classic question asking about Down syndrome screening. The key information being that she's 14 weeks pregnant, and it's a screening test, so not a diagnostic test for Down syndrome. So she's passed the window for the combined screening test because that's only from 11 to 14 weeks. And CVS and amniocentesis are the diagnostic testing that we do after the screening test. So yeah, this is the combined test. It's worth knowing what a sort of high risk result would look like. So that's having increased nuchal translucency, an increased beta-HCG, and a decreased PAP-A. And then the triple/quadruple test. I think essentially the quadruple test is a newer, better version of the triple test, and it adds one extra inhibin A. But yeah, the positive result or high risk result would be having a low AFP, low unconjugated estriol, and then a raised HCG and inhibin A. And then, like I said, if they had a high risk of Down syndrome, so less than 1 in 150, they would go on to have further diagnostic tests, which would be amniocentesis or CVS, depending on the gestation. Move on to the next one. Here we've got one answer in the chat. Anyone else have any ideas? Okay, quite a mix coming through. It's quite a hard one, so oh, okay. Should we reveal? Right. So the answer is D. We'll go through it. Essentially, so a man with HIV with tonic-clonic seizures, and then we've got some LP results. So there are quite a lot of differential diagnoses for people with HIV who are not compliant with their antiretroviral therapy, and they all sort of present similarly because it'll just be neurological symptoms. But in SBA land, there'll always be clues to what they're trying to get the answer to be. So it'll either be an LP result or some imaging descriptions. So essentially the clue is the LP, and this is just classical of cryptococcal meningitis. So it's normal glucose and protein, so it sort of leads you away from the TB answer of E, but it has lymphocytes and a really high opening pressure. and you essentially just have to know that that's Cryptococcus, and then the way you diagnose that is with the India stain. So if it was this progressive multilocal encephalopathy, that would be an MRI. Basically, they'd give you a description of MRI. Same with toxoplasmosis. And then the cysts on silver stain, that would be describing pneumocystis. So similar to the India ink stain, but yeah, just slight differentiation there. Does that make sense? I hope so. But yeah, it's quite a hard one. Any other answers? We've got one in the chat. Got two people saying D. Anything else? Okay, we'll go through it. So the answer is B. Well done, Millie. This is again another hard one. Similar to the last one in the sense that there'll be a few differential diagnoses for gastroenteritis type picture in people with HIV who are non-compliant with their antivirals. So essentially, cryptosporidium is a good differential, but because of this blood result with the raised ALP and LDH, that is what's leading you towards this mycobacterium. And essentially, it's just classical that it has liver and spleen involvement, hence why you get these markers in the blood raised. I think if it didn't have that, then cryptosporidium would be a really good answer, as it also causes non-bloody diarrhea. I have a thing, here that it's how I sort of thought about it in my head with the different things that can cause this sort of picture in people with HIV. So Campylobacter and cytomegalovirus can also cause a similar picture, but with bloody diarrhea. I just found that quite useful. But yeah, if you ever see this sort of liver, spleen, ALP, LDH involvement, the answer will pretty much always be this mycobacterium. Okay. I've got a few people saying C, so well done. That's the right answer. The stem is describing homocystinuria with this sort of weird array of symptoms, and it causes cysteines in the name, stones, which are radiopaque. Got slides here about renal stones. So the most common would be calcium stones, particularly calcium oxalate. But it's also worth knowing about the struvite stones, which you get from like the Proteus bacteria, and it's in alkaline urine. And then urate stones, the clue in the SBAs would normally be that they've either got gout or like a hematological malignancy or having chemotherapy, anything that causes like high tissue breakdown. And then cystine would be the symptoms that we discussed. So yeah, the myopia, learning difficulties, that sort of thing. And then it's also worth knowing a little bit about where stones get stuck, and it's where they're narrowing. So like the pelvic-ureteric junction, vesico-ureteric junction, and where the iliac vessels cross the ureter. But yeah. Anyone else have any answers for the chat? Got one so far. Okay, move on. So the answer to this one is D. Essentially, the stem is leading you towards metastatic renal cancer. So basically because of the raised calcium and the well circumscribed lesions, which is trying to get to like cannonball metastases. And we can also assume she might have potentially brain mets or because of the hypercalcemia confusion. The blood in the urine could make you think maybe this is bladder cancer, but just based on, we've got this like paraneoplastic syndrome with raised calcium, which is characteristic of renal cell cancer. And it's for the same reason that you get hypercalcemia in squamous cell lung cancer, because you get this like PTH-like peptide released. And the way you diagnose the primary cancer in this case would be a CT abdomen. Does that make sense? If the question was first investigation rather than most helpful. Potentially, yes, but I still think based on the stem, you're thinking renal cancer is the primary rather than, I mean, you're right, you probably would want to do a lot of these other things as well. But diagnostically, yeah, you want to do the CT. Does that make sense? Cool. Any other ideas? A few more. So the answer to this one is C. So obviously the STEM is getting at PCOS, but it's just testing how well you know the hormone profile results with PCOS. So we would expect sex hormone binding globulin to be lower, and LH we would expect to be higher, or more specifically, we expect the LH to FSH ratio to be high in PCOS, and that's because the LH is raised and the FSH is normal, hence why C is the right answer. And then we'd also expect raised glucose and raised testosterone. Okay, hope that makes sense. Okay, I've got a few answers coming in. So the answer in this case is E, and we'll go through why. So how I go about questions like this is I think how we're taught to in one of the CPP sessions, I like draw out this thing. And it's same with OSCEs as well. I think it's really helpful. So, her cycle is 30 days. And based on that, you know that her expected date of ovulation is day 16 because it's 30 minus 14 is how you work out the ovulation date. And it's now day 18 and her oopsie was on day 12. So you're right that she's outside of the window for the levonorgestrel because that would have to be taken within 72 hours or day 15. And she's also outside the window for LA1 because that would have to be 5 days after oopsie. And obviously, the thing about the IUD is the window is 5 days after the oopsie or 5 days after the expected date of ovulation. So in this case, she can have the IUD until day 21. I hope that makes sense. But this is always the way I do it. So the IUD can be inserted either 5 days after unprotected sex or 5 days after the expected date of ovulation. So in this case, she can still have it for another 3 days. Got a lot of people saying C, which is the correct answer. So essentially, the combined pill has estrogen, and hence you should avoid it in women with a history of obstetric cholestasis. It's quite a niche fact. But I think because the pathophys of obstetric cholestasis is to do with the changes in hormones that happen with pregnancy, especially estrogen, you just have to avoid it afterwards as well. But generally in questions like this, with exam technique, you can sort of, if they're asking about what sort of contraception should be avoided, if the combined pill is an option, it's normally always the right answer because there are so many contraindications. So even if you didn't know that, you could have probably guessed that it would be the combined pill. Yeah, Molly, good question. I'm not sure exactly how long you have to avoid it for. I didn't actually know that fact until these slides were given to me. But I can look it up for you afterwards. Got one answer for this one. Any other ideas? So well done, guys. The answer is D to this one. So it's just testing how well you know how to treat BPH. And essentially, it's between finasteride and tamsulosin. And the only one that works quickly is the tamsulosin because it works by relaxing the smooth muscle. Whereas finasteride takes up to like 6 months to work because it works to actually reduce the size of the prostate. So if we just go through BPH management quickly. Remember always, especially in OSCE settings, to talk about the conservative management. So for stuff like this and with urge incontinence, it's stuff like don't drink too much before bed, try and void before bed, don't drink as much caffeine, alcohol, containment products, stuff like that. And then medical is the alpha blockers, like we already spoke about. It's worth being able to list off some side effects for this, especially postural hypertension in the elderly. and then the 5-alpha reductase inhibitors, which take a bit longer to work, like you spoke about. And again, the side effects for this one as well, slightly different but similar. And then surgical management, we have transurethral resection of the prostate. And again, worth knowing some of the side effects for that as well, just in case there's like a counseling station or something. But yeah. Got a few people saying D, which is correct. So she's got severe pain, bleeding, and open Oz, and then we can see some of the products of conception in the vaginal canal. So how do we differentiate the types of miscarriage? Essentially, a threatened miscarriage, there'll be some bleeding, but the key is that the Oz will be closed and there'll still be a viable pregnancy on scan. An inevitable miscarriage is slightly different, and there's bleeding, pain, and the Oz will be open, but the products of conception are still within uterus. Incomplete, like this case, again, bleeding, pain, Oz is open, and you'll see the passage of some of the pregnancy in the canal, compared to a complete miscarriage in which the Oz is now closed. There's no more pregnancy in the uterus. And then the missed miscarriage, I think, is the most confusing one. Essentially, there's not necessarily any symptoms. The Oz is closed, but on scan, we can see that the pregnancy is no longer viable. So yeah, I hope that makes sense. Okay, I've got a few different answers coming in. So the answer to this one is D. This is also quite a tricky one. I think the key part here is what's the next best course of action? Anyone with acute urinary retention, the next best step is to catheterize them just to relieve the not relieve the obstruction, relieve the pressure. And then following that, you can sort of try and figure out what the cause of the retention was and how we can treat that. So if there was a stone, for example, or a stricture or something obstructing the ureter, then nephrostomy would be the best thing to do after that. But initially, we should be catheterizing patients. So this is quite a busy slide, but essentially we'll go through some of the causes. So it could be obstructive. Like we mentioned, it could be a stone, a cancer, BPH, stricture, could be caused by medicines or neurological causes. Or in this case, this guy just had a UTI and that can be enough to cause urinary retention. And then some of the symptoms there, especially delirium, is a good cause of delirium to list off in an OSCE. And then the management, like we said, first of all would be just to catheterize. And that would also help in your diagnosis as well when you drain a certain volume of urine. And then treat the underlying cause. I hope that makes sense. And lots of people saying D. So yeah, this one's quite straightforward. Out of all of these, it's the only one that's a risk factor for an ectopic pregnancy. Yeah, some other risk factors be endometriosis, having a previous ectopic, having a coil in situ, previous surgery in the area, IVF. And then the key symptoms is unilateral pain, bleeding, and then examination findings, unilateral abdominal pain, cervical excitation, and then peritonitis potentially if the pregnancy ruptures. Yeah, some investigations and things, but it's all quite straightforward, I think, ectopic pregnancy. So. Everyone seems to be in agreement that the answer is B, which is well done. So essentially we've got some signs on the CTG that are very abnormal and the baby needs to be delivered. So the late D cells and also this fetal bradycardia of less than 100 for more than 15 minutes is a bad sign. And we can't do von 2s because the cervix is only 7 centimeters dilated. And these hormonal adjuncts are contraindicated if the fetus is in distress. So yeah, the right answer is C-section. Well done, guys. Okay, yeah, everyone's right. It is A, first-line treatment for eclampsia. It will help to protect the brain. It helps to relax the blood vessels, and it also lower the blood pressure. Labetalol will also be helpful in this scenario, but it's not as important as the Magsolve. So yeah, cool. Okay, we've got some different answers coming in. Consensus seems to be that the answer is C. Well done. It is C. So we can go through it briefly. I used to find syphilis serology quite confusing, so ask any questions if you have them. I'll do my best to answer. So basically, he's got these positive test results. He's got the positive, specific and non-specific tests, and then we see the titer decrease by 8-fold and then increase again by 4-fold. Hence why he's been effectively treated and then reinfected. So if we just go through syphilis serology quickly, so you have these cardiolipin tests, which are the non-specific ones. And these are the ones that we need to test just to see if we've successfully treated the syphilis because they become negative after treatment. However, there's lots of causes of false positives. So we've got them at the bottom here: lupus, TB, antiphospholipid syndrome. Hence why we need to do these specific antibody tests that always end in A, is how I can differentiate them. And they stay positive after treatment, but it will confirm whether or not your non-specific test is a true or false positive, if that makes sense. So in this case, yeah, he's positive, all of them, but then we look at the titer of the non-specific test. And I used to get confused about whether high or low is positive. And if you just think about it as the number of times you're diluting the sample to get rid of the syphilis is how it works. So basically a higher is worse. There's more syphilis there because you have to dilute it 64 times to get rid of it, if that makes sense. And then the key number is this 4-fold increase or decrease. So we want to see a fourfold decrease in the titer to say we've successfully treated the syphilis. And in this case, like I said, he went down, he got treated, and then it went up again fourfold, so he got reinfected. I hope that makes sense. But yeah. Okay, we're about halfway. I'm aware we've gone quite quickly. Is everyone okay with the speed, or do you want me to slow down? And also, you can fill in the feedback form now, but we've got another opportunity at the end as well. All good? Okay, cool. So yeah, got about another 15, 16 questions to go. Okay. Do we need a breather, or can we carry on? Okay, cool. Let's keep going. Okay, I've got a few people saying E. Which is the right answer. So this is urticaria. I think I added a picture for the next one. Oops, I was supposed to put it before as well. But yeah, normally it's a clinical diagnosis and it will settle with antihistamines and potentially steroids if it's severe. And then these other things might be needed to test later on if the symptoms aren't resolving or they can't identify what the triggers are. But normally there's no tests needed. Yeah, potentially that was supposed to be ESR. I'm not sure. I didn't write that one, so that it could well be that. Sorry. Okay, everyone's saying D, which is correct. This is essentially secondary to friction, and it can lead to candida growth, which then looks like this, which is also very common in these areas. And you can tell the difference based on the like satellite lesions. And if it looks more like this, then you're thinking, yeah, candidiasis, needing some antifungal creams, that sort of thing. But before that, that's just known as intertrigo, apparently. So yeah. I've got a few answers. Leave it a couple more minutes. So this one is A. So the stem is describing and the picture is of a squamous cell carcinoma. And we excise that with a 4 mm margin. The B option, the 2 mm margin, is what we do for suspected malignant melanomas. And then based on the Breslow index after that initial 2 mm excision, you'd then further excise it depending on how deep it went. But for basal cells and squamous cells, we just excise it with a 4 mm margin and call it a day. Hope that makes sense. Okay, I've got a few answers. Any others? Okay, so this one is C. Well done. She needs to take her missed pill and then continue the pack and then start a new one straight away. So if we go through the missed pill rules, because it can be quite confusing. Basically, if you miss one, it's fine. You just take the missed one and then keep taking. Gets a bit more complicated if you miss two or more. The way I think about it is basically you're protected from pregnancy if you take the combined pill for 7 days in a row. Hence why if you miss them in week one, you've just had your pill-free interval. You've not had a 7 day consecutive row of pills. So you need to, if you have unprotected sex and you've missed a few pills in week one, you need potentially to have emergency contraception because you might be pregnant. And then again, take the last missed pill, don't worry about the other one, and then continue taking it. And then you're going to need to use barrier contraception for 7 days as well, until you've been taking the pill for 7 days consecutively, and then at which point you're protected. So that's why in week two, because you've already been taking it for week one for 7 days, you're fine, you're not pregnant, but just take the last missed pill and then continue taking, nothing else to do. Week three, you take the missed pill, finish your current pack, and then, like in this question scenario, you need to then miss out your next pill-free interval because, like I said, you need to be taking it for 7 days continuously to be protected. So if you go onto your pill-free interval, you won't be taking it for 7 days before that, if that makes sense. So yeah, I hope that's how I always think about it based on that. And in this case, she's day, I think, 17. So she's in week three. And then with the progesterone only pill, it depends on the pill, but they're a bit stricter with the timings in terms of lateness. So you're late if you're 3 hours late, or with the newer ones, 12 hours late. And again, it's take the missed pill, continue as usual, but you need to use barrier contraception for 48 hours afterwards. Okay. Okay, got a few people saying E, which is the correct answer. So this is one of the ones I think it's worth knowing, the 2 week wait referral criteria. Essentially, if there's a lump, everyone needs to get referred. It's just a question of whether it's an urgent referral or a non-urgent referral. So if they're less than 30, it's non-urgent. But if they're over 30 with a lump or over 50 with any concerning nipple changes or skin changes, they need 2 week wait referral. But yeah, in this case, any sort of lump needs referring. A lot of people saying E, which is the right answer. Well done. So it's the same for endometrial cancer. Essentially, anything that causes increased lifetime exposure to estrogen is a risk factor. So if you haven't had a child, then you're having more menstrual cycles because you've not been pregnant for 9 months, hence more estrogen. Same with early menarche, late menopause, the combined pill. So yeah, of these, this is the only one that's a risk factor. everyone seems to be in agreement that the answer is B. Well done. It's just a bit of a facty one you have to learn, I think, that the treatment of antiphospholipid syndrome in pregnancy is aspirin and low molecular weight heparin. Yeah, just got to learn it, I think. But I think Passman quite likes this question, so it comes up a lot. Okay, yeah, well done. The answer is B. Yeah, this is mastitis, and it's important that you encourage breastfeeding when someone has mastitis. Okay, well done, guys. Yeah, the only one of these that can be used is cabergoline. So it's a dopamine agonist, and obviously lactation is under suppression by dopamine. So give cabergoline or bromocriptine to stop it. Or one answer so far. Okay. Yeah, well done, guys. The only one of these that's the absolute contraindication is the blood pressure. So if we go through some of the, so I think it's worth learning the MET4 ones for the combined pill. Most important ones that come up in SBAs, I think, is this age and smoking one. So being over 35 and smoking more than 15 cigarettes a day, obviously having migraine with aura, having a history of VTE, stroke, you're breastfeeding in less than 6 weeks postpartum, uncontrolled blood pressure, which is more than 160 over 110, any current breast cancer, and then, prolonged immobilization, antiphospholipid syndrome. Yeah, well done. Got a lot of people saying A, which is the right answer. So yeah, we reassure until they get to 2 years old or they're having recurrent symptoms, balanitis or ballooning, in which case we would circumcise. But at this point, it's only one and there seems to be no other symptoms. So just leave it for now and hopefully it will self-resolve. Okay, we've got some A's, some C's. The answer is C. Anytime you're doing a NATS test for men, it is a first catch urine. And when you're in the sexual health clinic, remember they're often asking in history, when was the last time you passed urine? Because I think it has to be at least an hour, having not voided, before you can do an accurate first catch urine sample. So yeah, worth knowing. Okay, everyone's saying B very quickly. Yeah, that's the right answer. So obviously trimethoprim is a folate antagonist and can't be used in the first trimester. So nitrofurantoin for 7 days is the correct answer. And it's important that we do treat UTI in pregnancy, even if there's no symptoms, just because of the risks of pyelonephritis and fetal mortality. Okay, got a lot of people saying C, which is again correct answer. Well done. This is sort of thing you just have to learn, the P450 enzyme inhibitors and inducers. It's something I should put in my short-term memory before exams. But no, it's worth learning, especially for the PSA next year. And rifampicin is a inducer. So okay. A lot of people saying B, which again is the right answer. Yeah, I found this out when I was researching the question. Apparently smoking actually reduces your risk of getting preeclampsia, which they don't know why, but there you go. And being a primip. I think the main reason a primip is a risk factor is just because they don't know how you're going to respond. Whereas if you've had a previous pregnancy that didn't have preeclampsia, you're probably not going to have it again. So primips is not necessarily a risk factor, but it's more like just erring on the side of caution. I think PassMed has a good table about the high risk and the moderate risk things for preeclampsia. But some of them are listed there. Yeah, cool. Okay, we've got a few answers. So the answer to this one is D. I added this question just because I didn't think we had anything about HRT or menopause. It's quite hard, it's quite a lot of steps to it, and it's inspired by a question that we had for the PSA. So there are a few steps to it. Essentially, she wants to no longer have this withdrawal bleed or breakthrough bleed type thing. And you have to know which type of HRT has a withdrawal bleed or a monthly bleed versus which one doesn't. So the sequential HRT is what will give you this bleed, because you take estrogen every day and then you take progesterone for only like half of the month, and that's what like mimics this cycle which causes bleeding. And she's currently using the transdermal patch, sorry. So basically what she's asking for is to be put on the continuous version of the HRT that doesn't have this bleed. However, because her last menstrual period was 9 months ago, she's not allowed to have the continuous type of HRT, because you have to have had your last menstrual period at least 12 months ago, or to have already been taking sequential HRT for 12 months, if that makes sense. And then this family history of DVT is just to help you rule out some of the systemic ones. So she's not allowed, well, we should avoid in her, because of the risk of VTE, we should avoid any systemic forms of HRT. So that rules out option A and option C. So basically she has to carry on with her current, we can infer that she's currently taking the sequential patch, and she has to continue with that until she's not had her period for 12 months. I hope that makes sense. But it is quite a hard question. There's quite a lot to it. But basically, this will just go a bit more detail. So how do you decide what type of HRT to give? The first question is whether or not they have a uterus. If they don't, then you can just give estrogen only. If they do have a uterus, then it depends when their last menstrual period was. If it's been over a year, they can have this continuous, and I'll put a picture of what the continuous one looks like. If it's been less than 12 months, then they need to be on this sequential HRT, which does tend to have a monthly bleed because of the different doses of progesterone and estrogen. So you can then move on to the continuous HRT if you've had the sequential HRT for at least a year, or it's been a year since your last menstrual period, or if it's been 2 years since the last menstrual period if they had POI. And then some of the contraindications to HRT are breast cancer, any other estrogen sensitive cancers, any undiagnosed vaginal bleeding, or untreated endometrial hyperplasia. I hope that makes sense. I know it's a hard question. Yeah. Okay, one more. That's contraindication to any HRT, not just systemic. I can go back. Yeah. Those for any sort of HRT, you can't have it if you've got any of that. It's got a lot of people saying E, which is the correct answer. So yeah, this is how you treat bacterial vaginosis in pregnancy. I think the guidelines changed relatively recently in that we can give metronidazole, but we should avoid this big dose that we can give to non-pregnant women, this 2-gram dose, because it's bad in pregnancy apparently. And then clarithromycin, that'd be a second line. Reassurance, can't do that because there's a risk of premature birth if you don't treat BV in pregnancy. And then clotrimazole, that's how you treat Candida. So yeah, well done, guys. That's it. Thank you. Happy to answer any questions, and please do fill out the feedback form. It's really useful. And I hope that was useful. Yeah, Mod C next Tuesday, SBAs.